Thank you, Jeff. I'm grateful to our funders, and I'm grateful to Restorative Therapies, who loaned us some bikes early for our research. And I'm really grateful to the folks here on the call. We could not have done this study without you. And I particularly note Amy and Deborah, who served on the steering committee, and Allison and Ian, who were with us from the pilot trial. So I really, really appreciate all that you've done and contributed. I'm grateful to our Methods Center personnel, and we've had some changes over the course of years, and we really could not have done this study without them. Big picture, it always comes back to the patients. And this is a professor of philosophy from the University of Toronto who had ARDS, and she wrote about how she felt weakness and fatigue. And over the course of the last few years, the number of studies on early mobilization in the ICU has really exploded. We started this research program with the Canadian Critical Care Trials Group in 2012, and you can see how quickly the literature has accumulated over time. You can see that a lot of the authors are primarily from the US, so we're starting to make a stamp from Canada, and we can see the influences of Margaret Herridge, Dale Needham, and Bill Schweikert on the larger field. Really, CYCLE came from a landmark trial that showed that if we started early physical and occupational therapy within 72 hours of intubation, more patients would be functionally independent at hospital discharge. Cycling started within the first 14 days of critical illness, improved 6-minute walk test at hospital discharge. And we showed that from a retrospective study that in-bed cycling could be safe. When we look at the early OT and PT, really the intervention of usual care really starts with passive or active assisted range of motion, progressing to active range of motion, bed mobility, sitting at the edge of the bed, moving to standing and walking, and this is all incremental based on a patient. In the ICU has ups and downs in their clinical trajectory, and to date, no one has replicated the results of this trial. CYCLE inspired me once I was working at Johns Hopkins because we were able to do in-bed cycling with patients, even if they were sedated and ventilated. And we noticed that patients could cycle actively even while they were sedated. So if we were to think of the previous model, we wondered that, well, could cycling be one way of providing in-bed activities as part of a toolkit for patients who require activities in bed? It's not something that we would prioritize with patients who are starting to do out-of-bed activities, but is this something that we could do with patients in bed? And really, you've all been part of this journey where we started as a single center study at St. Joe's. We progressed to our pilot RCT, and that's when Ian and Allison joined us. We did CYCLE Vanguard, which is when Amy joined us, and we recently finished our full-scale randomized trial. So I'm going to turn things over to Jeff to give us a brief overview of our methods and just remind us what the methods looked like for this study.
Thanks, Michelle. So just again, as Michelle said, we'll just kind of briefly go through the method. So just to bring up the research question again, question. In medical and surgical ICU patients, does 30 minutes of in-bed cycling usual PT started within the first 4 days of mechanical ventilation compared to usual PT alone improve patient function at 3 days post ICU discharge? Okay, and so with CYCLE, we randomized 360 patients across 16 centers and 3 countries. So again, they were randomized into either the cycling group or usual PT alone. And so for each of these, it was led by existing ICU physiotherapists at each site. And then, as I mentioned, the primary outcome is physical function at 3 days after ICU discharge. So the physical function in ICU test. And that measure was collected for the most part by assessors who were blinded to the randomized group. Okay, and next slide. So for eligibility criteria, the inclusion were adults. They were mechanically ventilated, or sorry, they were within the first 4 days of mechanical ventilation. They were within the first 7 days of their ICU admission. They were expected to have an additional 2 days of ICU stay. And prior to being admitted to the ICU, they could walk independently with or without a gait aid. And then you'll see here, there is a list of exclusion criteria, and a lot of them would have been just things that could affect their ability to bike or follow any commands or take part in the study in general. Okay, and next slide. Now, each day, the physiotherapists were reviewing these patients, and they were looking for temporary exemptions that could maybe prevent them from participating in treatment that day. So some of them just include increases in vasopressors or inotropes within the past few hours, an active MI or uncontrolled arrhythmia, a higher or lower mean arterial pressure, or if the treating team was not comfortable with them participating in care, a heart rate greater or less than 40 or greater than 140 beats per minute. Some of the respiratory issues could have been SpO2 less than 88%, neuromuscular blockers, and then some of the other ones could be severe agitation, uncontrolled pain, maybe the patient's goals changed to palliative care that day, or team perception that in-bed cycling or PT was not appropriate for other reasons. And then for CYCLE, the way the study schema was structured is that on ICU admission, people were randomized, again, as I mentioned. Then there were 4 major time points within the hospital where outcomes were collected. So that was at ICU awakening, ICU discharge, the primary outcome 3 days after ICU discharge, and hospital discharge. So again, as we mentioned before, they would have received the intervention while they're in the ICU. Once they were discharged from the ICU, they would receive usual PT on ward prior to their hospital discharge. And then the last test that was collected was 90 days after randomization. The patient was followed up via phone call and to capture some quality of life measurements, their access to healthcare after they had left the hospital, just to have a better understanding of what that person or individual was like after their stay in the ICU. The secondary outcomes that were collected are duration mechanical ventilation, length of stay in the ICU and hospital, mortality rates, their discharge location, muscle strength, and ICU acquired weakness. Some of these were not captured in the PFIT, so they're collected after. Their frailty scale, their physical function, their mental health, and then, as I mentioned earlier, participation or quality of life scales after their stay in hospital. The other thing that we were collecting during the study were just any adverse events. The main ones that we were reviewing just to make sure that it was safe to deliver cycling were serious adverse events. So we classified those as unplanned extubation, cardiac arrest, or patient falling to their knees during physio. And then some of the other adverse events are very similar to the daily screening that we saw earlier as well. So if a patient met any of these criteria, then we would capture that in the adverse events forms and we reported those as well. Okay, thanks, Michelle.
Briefly, we needed to,
And then,
sorry.
go ahead, Michelle, you're good.
I know I didn't give you the slide last time. So briefly, we needed to roll 360 patients. We were looking for a 1-point difference in PFIT, and we're really grateful to our International Data Safety and Monitoring Committee. We submitted safety reports every 6 months after the 180 patient interim analysis. maybe we'll pause here in case there's any questions about the methods or intro. Feel free to add stuff into the chat. And all of you would have seen this in our manuscript. So in terms of results, we enrolled 360 patients at 16 centers in 3 countries. We were in both academic and community ICUs. Our method center led at least 75 training sessions and engaged almost 160 frontline ICU interventionists and ward-based outcomes assessors. So really embedded, partially embedded in the healthcare systems, working with the people who are already at our respective hospitals. This gives you a flavor of the people involved with CYCLE, and it's really been one of my career highlights to work with each of you. And just to give you a sense of your own sites, here's your group at Duke, Amy, where we did one of our startup sites. Allison, I'm not sure if you can see this, but you've got your cohort of people here at the Hamilton General. And here's your team at London Health Sciences. And I'd like to send a particular shout out to Ian because he also sought funding for CYCLE, and that funding really helped us get the study over the finish line. So a huge shout out to you, and thank you for believing in this study from the very beginning. And here's our team at St. Joe's, which includes some of our Method Center colleagues. So it's really the faces of the people that make the research happen. And it's been such a delight to be able to work with everyone. In terms of our consort diagram, research coordinators screened, identified 6,000 patients who were potentially eligible. However, 5,000 had exclusion criteria. Overall, our consent rate was 81%, which is really fantastic. And we randomized 178 to cycling plus usual PT and 182 to usual ICU PT. These next 2 slides show the baseline characteristics, and the important message to take away from the baseline characteristics is that they were balanced at randomization, and our patients were quite similar to a typical ICU patient, with the same proportion of females admitted to the ICU. We had a fairly sick patient population with Apache 2 scores of 24 and 23. Most were living at home independently and did not have frailty, nor did they have many comorbid conditions at baseline. Again, in terms of baseline characteristics, balance between groups. In terms of the proportion of medical admissions, our cohort was primarily medical and not surgical. There was a high proportion of people who had vasopressors inotropes, and about 10 to 14% requiring renal replacement therapy at baseline. In terms of randomized intervention delivery, a tremendous shout out to the research coordinators who screened and consented patients, and to the physiotherapists who, once we had patients on study, were able to start the intervention within the first 2 days of either ICU admission or start of mechanical ventilation. Our protocol adherence and fidelity was high, in that almost 90% of all patients received both a cycling and usual physiotherapy session. 94% received at least 1 usual physiotherapy session. And you can see that the number of days where cycling or usual physiotherapy occurred was relatively small. So 3 days of cycling and 4 days of usual physio. There was separation between the groups in that cycling and usual physiotherapy was about 47 minutes, whereas usual physiotherapy alone was 29 minutes. These numbers were reflected direct care and did not include setup or takedown time. The amount of usual physiotherapy is the most that's been recorded to date in any ICU rehab study. If we look at cycling alone, cycling started within 2 days of mechanical ventilation. There were about 3 sessions per patient. The sites, I'm so grateful. We delivered 27 out of 30 minutes planned, which is 91% of the planned intervention per session. And per session, patients spiked about 1 kilometer. In total, this accounted for just over 1,200 kilometers, which is the distance from Hamilton almost to Fredericton, but just short of Edmundston, New Brunswick. If we look at adverse events, the adverse event rate in the cycling group was 9.2% of patients compared to 5.8% of patients in the usual physiotherapy group. However, if you look at cycling only versus usual physiotherapy, the adverse event rates are similar. If we look across all of the sessions, the adverse event rate is slightly higher in the cycling and usual physiotherapy group versus usual physiotherapy. However, there were also more opportunities, and you can see more opportunities for more sessions. Important to note, there were no severe adverse events in either group. If we look at our primary outcome, higher numbers represent better function. And while the patients in the cycling plus usual physiotherapy group had a higher PFIT score, this was not statistically significantly different than usual care. This was again measured at 3 days after ICU discharge. In terms of our subgroup analyses, there was no difference in subgroup. However, these are underpowered. So there was no difference by age at baseline, no difference in patients who did or did not have frailty. Patients with frailty were identified as those who had a frailty score of 5 or higher. And there was no difference between males and females. However, it is interesting to note that although underpowered, there may be more of an effect in patients with frailty at baseline and females. There were no differences in 5 sensitivity analyses, so our results were robust by the analysis.
Michelle, I'm just curious, of the, what was it, 42 that had a, CFS 5 or greater, what was the proportion of males and females in that 42?
That's a great question. I'm happy to look that up. I don't have that off the top of my head. I don't know, Jeff, if you're aware of those for that breakdown.
Yeah, I can't remember right now either, Amy.
But I can look that up for you, Amy. Other questions?
I'm just sorry, that frailty very much interests me. Of course, it's so if you did, so it's really about 12%, 42, right, of the population. And we knew they were relatively healthy going in. Yeah. So I'm curious to know who those other ones were, since those, if there's going to be an effect, it seems like that would be the one that would potentially, even though I know it's not statistically significant, right?
Yeah.
But just,
Isn't it? And then the females, which is interesting because females have worse outcomes post ICU. So that to see more of an effect in females was interesting as well.
Yeah, I'm just wondering if the majority of those with a 5 or
Mm.
greater is female.
Right. Well, we can certainly look into the database for that.
Mhm.
Moving on to the clinical outcomes, what this gives you is a sense of the patient population. So patients were mechanically ventilated for about 5 days. They were in the ICU for about 11 days. Mortality was about 18% in the ICU. Hospital discharge, they were in the hospital for about 3 weeks. And it's important, I'd like you to note that they were in the hospital for about 3 weeks. So they're in the ICU for 11 days and in the hospital for 2 weeks or 3 weeks. And our mortality was about 22%. This is actually lower than the ICU mortality was lower than what we projected it would be because we anticipated the ICU mortality would be about 20%. In terms of secondary outcomes, there also were no differences in secondary outcomes at the other time points. And something that we started to get a bit excited about, but recognizing that none of these were statistically significant and they're underpowered, is that we're seeing some similar trends across the outcomes. So patients who were randomized to cycling and usual physio, fewer patients had ICU-acquired weakness. Frailty was lower at hospital discharge. Patients reported better physical function. And we're one of the first studies, or if we're the first study to have a patient-reported functional score in acute care. There was no difference in PFIT. Patients achieved 1 additional sit to stand, and they walked farther in the 2-minute walk test. Again, none of these are statistically significant. They are underpowered. However, what we do see is consistency in results across these outcomes. Jeff, I'm going to turn things over to you. And I'd like you to remember that people before they came into CYCLE were primarily independent living at home, and they were only in the hospital for 3 weeks.
Okay, thank you, Michelle. So in this box plot here, we've broken it down into 3 of the time points. So ICU discharge, 3 days after ICU discharge, and hospital discharge. And in this box plot, we're just trying to capture a patient's score for the 30-second sit to stand. So as you see, as Michelle mentioned, that as we get closer to hospital discharge, the cycling group performed slightly better than the usual PT group. But what we want to highlight here is mainly the lines that appear on the plot. So as you'll see here, the red dotted lines are the aged and sex cohort norms for men and women. And you'll see with the patients that we had in CYCLE at hospital discharge, their scores were much lower than you would expect for healthy adults at the same age. And their scores were even lower than what we'd expect for 90-year-olds at their age, or I'm sorry, with these same measures. So it's just kind of startling just to see how much of an impact the ICU stay had on the physical function for some of these patients. And the next slide, Michelle. And then we found very similar things in the 2-minute walk test as well. So for the 2-minute walk
Sorry,
test,
could you just go back to that just for a second?
sure.
Yeah, okay. I was looking at the 3 days ICU compared to what there were at hospital discharge. Okay. Yeah, not too much of a difference. Okay. Thank you.
Okay. And then for the 2-minute walk test, we had age match norms as well, age and sex match norms. But the closest functional norms that we had were between 70 and 79 years old. And again, with the 2-minute walk test, we see that the patients, when they were discharged from the hospital, their function levels were even lower than that as well. So again, just to kind of highlight how stark it is of a difference for these patients compared to what you'd expect for healthy people at their age. Okay,
I
thanks,
would
Michelle.
to commend Jeff. Jeff was the one who created these plots for us, and we're so grateful for what he envisioned for us. So I'd like to shout out to Jeff for these excellent figures.
Thank you.
You're welcome. CYCLE had limitations in that it was an unblinded intervention. We had limited cycling exposure. It was 5 days a week because that's how our units were staffed. We conducted cycling until someone could march on the spot, only until someone could march on the spot, because we anticipated that clinically we would use cycling and we would focus a physiotherapist's time on other activities once someone's out of bed. And we did not protocolize usual ICU physiotherapy. However, we did conduct performance-based measures, and the assessors were blinded to treatment group. We conducted this trial that was partially embedded in the healthcare system. We had high intervention fidelity, and we conducted it in academic and community centers. I'm going to help to contextualize CYCLE within the larger group of ICU rehab studies. And you may have heard of TEAM. This was published in the New England Journal in 2022. This looked at high-dose active rehabilitation, and their primary outcome was the number of patients alive and out of hospital at 6 months. This study enrolled 750 patients in 49 centers in 6 countries. We're similar in that our time to start was about 2 days, and our cohorts were similar in terms of ICU and hospital length of stay. Our cohort had higher Apache scores, indicating a higher severity of illness at ICU admission. And we also had a longer duration of intervention. However, the intervention was measured in different ways, whereas we measured the total duration. The TEAM trial measured the number of active minutes of physiotherapy. Another trial that was published in Lancet Respiratory Medicine looked at early physical and occupational therapy and cognition measured by the MoCA score at 1 year. The group is the same Chicago group, which enrolled 200 patients. They started their intervention within a day and change. And this was done in a medical ICU, which we don't have in Canada. Their ICU and hospital length of stay was shorter than CYCLE. However, their Apache scores were similar to CYCLE. Unfortunately, they did not report information on the duration of their intervention. So you might be wondering how CYCLE fits into the larger cohort of ICU cycling studies. And I'm delighted to have Dr. Heather O'Grady with us, who will share results of a recent systematic review and meta-analysis.
Thanks so much, Michelle, and hi everyone. It's great to see you online. As Michelle said, I have the honor of sharing some additional recent work that we did in tandem with the completion of CYCLE, and that was to conduct an updated systematic review and meta-analysis of specifically cycling. So first, I just want to take a step back and recontextualize for us what we already know about the broader field of cycling literature. So Alison Takaoka, who's an alumnus of our group, conducted a systematic review, which was published in 2020 and looked at both the safety and efficacy of in-bed cycling. And in this review, Alison found that cycling was safe, but didn't find any added benefit of cycling versus comparator groups across several outcomes. In 2022, Michael Wang published another systematic review that looked at ICU rehabilitation more broadly. But in this review, they did do a subgroup analysis that included cycling as one of several different types of interventions and found a potential signal for benefit both for physical function and length of stay. And then, of course, neither of these systematic reviews included cycling, which I'm sure we are all well aware by now that it is the largest trial of in-bed cycling in the field to date. So with the potential signal of benefit, and then with these new data, we wanted to update Allison's initial systematic review. So next, I'll just briefly highlight the methods for you. In this update, we did only include randomized control trials that enrolled adults admitted to any ICU for at least 24 hours, and they may or may not have been mechanically ventilated. We included any cycling intervention as long as it was started in the ICU. So this means that it could have been cycling alone, or it could have been cycling as a multi-component intervention alongside other rehabilitation activities. And then we didn't restrict by comparator as long as patients in the comparator group did not receive any cycling at any point. And then we looked at 8 outcomes. Physical function was our outcome of interest, but we also looked at length of stay, safety, mortality, muscle strength, ICU acquired weakness, duration of mechanical ventilation, and quality of life. And next, I'll just briefly highlight a few more methods for you, but we conducted our screening, data extraction, and risk of bias assessments independently and in duplicate. And we conducted random effects pooled meta-analyses for outcomes that were reported in at least 2 trials. And then for outcomes that were the same unit of measurement and the same time point, we used mean differences. But for heterogeneous outcomes, we used standardized mean differences. And then we used pooled proportions to look at safety events. Where applicable, we looked at outcomes at ICU discharge, hospital discharge, and then we looked at the most proximal post-hospital outcome measures as well. And then lastly, we used grade to contextualize our results. Next, I'll just briefly highlight the included studies for you. So in the initial systematic review led by Allison Takaoka, there were 14 studies. 2 of these were non-RCTs. So given the fact that we anticipated an increase in available evidence and to reflect the highest level of evidence, we only included RCTs in the update, which means that there were 12 trials included from the initial review. We then screened just over 5,000 citations and more than doubled our included studies with an additional 21 trials for a total of 33 trials included in the updated review. This next figure I'll walk you through summarizes the 33 included trials. So on the left-hand side, you'll see the primary study authors with the flags representing where the studies were conducted. So I just want to highlight that there were only 3 multi-center trials, 2 of which were CYCLE, so CYCLE Pilot and CYCLE Full. And then the other multi-center study was led by Sue Burney in Australia. And then there were only 2 international RCTs. As we move to the right, I'll briefly explain what the lines mean. The solid lines are the periods of study recruitment, whereas the dashed lines are the period between completion of recruitment and study publication. The pink lines represent interventions that were primarily focused on cycling, and those were just over half. The black lines represent cycling as part of a multi-component intervention. So across the 33 trials, there were 3,274 patients included. And I'll just highlight a few more details about the studies. So as I said, they were mostly single center with a median of 1 center per study. And they were smaller trials with a median of 74 patients enrolled per study. And about a quarter of studies were conducted in mixed ICUs, and about a fifth were in cardiac ICU. So definitely some diversity in the ICU types. And next, I'm just going to highlight some key findings from our outcomes of interest, which is physical function, and then as well as length of stay and safety. So first, we'll present 3 forest plots for physical function. I'd just like to flag for you that anything to the right of the vertical line represents a benefit for cycling versus comparator groups. And on the left-hand side of the screen, you'll see individual studies with the different outcome measures used in brackets. So this first forest plot summarizes physical function at ICU discharge. And this was reported in 12 trials, just shy of 1,300 patients. And we found that cycling may improve physical function at ICU discharge. Next, we have physical function at hospital discharge. And across 7 trials, 645 patients, we did not identify an effect on physical function at hospital discharge for cycling. And our last physical function time point was post-hospital. And across 8 trials, 865 patients, we found that cycling may also improve physical function post-hospital. Next, we'll present 2 forest plots for length of stay. So I'd just like to flag for you now that anything to the left represents a benefit for cycling, so it's flipped. And the first time point is ICU length of stay. So across 29 trials and just shy of 2,600 patients, we found that cycling decreased ICU length of stay by 1 day. And the next forest plot is hospital length of stay. So across 22 trials, just shy of 2,100 patients, we found that cycling decreased total hospital length of stay by 1.5 days. This last figure summarizes adverse events. So this is where we used pooled proportions to look at safety events. So we looked at these where we were able at both the patient and session level. And I want to highlight first that we didn't identify any serious adverse events associated with cycling or in comparator groups. And in general, adverse events were rare, representing 1% of patients and 1% of sessions for the cycling groups. We didn't identify any effect for remaining outcomes of mortality, muscle strength, ICU-acquired weakness, duration of mechanical ventilation, or quality of life. Now I'd just like to summarize some limitations and strengths for you. So I'm sure that you noticed from the language, the grade language, that we identified a low certainty of evidence for all of our outcomes except for one. So we think that's primarily due to the fact, well, a few reasons, but I'll highlight a few key ones for you. So first is the nature of the intervention, of course, is unblinded. So we're unable to blind providers or the patients who are receiving the interventions. And we also identified significant clinical heterogeneity in the ICU populations included, in the interventions that were delivered, the measures that were used, I'm sure you noticed with the physical function forest plots, and as well as in the time points at which these measures were assessed. And then lastly, as I highlighted before, most of our trials included were single center. And in terms of strengths, we did use independent duplicate processes throughout the review. And our review is also recent, including trials up to June of 2024, which of course is CYCLE. And although we did identify low certainty of evidence, there were consistent findings across multiple outcomes, which I think increases our confidence in the results we found. And then I'd like to just take a moment to acknowledge all of the work that's included or represented by this review. So in these photos, you'll see some of the authors represented across the 33 trials. And I think what's been really neat about doing this systematic review kind of alongside the completion of CYCLE and the results is that it really becomes clear that the evidence is stronger together, and it's all of the work from all of these authors that has allowed us to find these exciting results. So just to conclude, in our systematic review and meta-analysis, which represented 33 trials, 3,274 patients, we found that in-bed cycling as part of the ICU rehabilitation strategy improved physical function at ICU discharge and post-hospital, decreased ICU length of stay by 1 day and total hospital length of stay by 1.5 days, and was associated with rare adverse events. So we think that this means that cycling could help give patients a head start on their recovery journey, could help them get home faster, and when led by trained ICU therapists and of course the ICU team, we think that cycling can be safely incorporated into ICU rehabilitation. And I'd like to hand things back over to Michelle.
Thanks very much, Heather. Heather was invited to present the systematic review recently at the European Society of Intensive Care Medicine in Barcelona. Here on this slide, you can see the QR codes to each of the papers, and we're more than happy to send you both the papers if you don't have them. And I'd like to finish this talk with the words of an ICU survivor, in that rehabilitation is a necessity to ensure that patients' lives are worth living after an ICU stay. So that is what we've got so far for CYCLE. We're happy to take any questions and also have some other questions queued up for you, but we're happy to sort of put it to you and see what you see your thoughts or hear your thoughts.
Michelle, one of the things that came up because we would start to talk about using the Liberation Bundle and where the bicycle fits into that is timing of bicycle, right? Mobilization's important, physios are doing that, but given all of this, particularly, and Heather may know the answer better than you in terms of the systematic review evidence, where do we think cycling fits in? Is it for the patients we can't mobilize? Is it where is it going to fit in our physio armamentarium now?
Heather, would you like to speak to the evidence, and then I can comment from a clinical perspective, and Amy, as a physio, I'd love your thoughts as well.
Mm-hmm. Yeah, for sure, Allison. So I think your first point was around kind of timing. Certainly time to initiation of cycling was very heterogeneous in the studies that we included, if it was even reported. So I think that definitely is one of the limitations or one of the challenges from the body of evidence, is determining when might be the best time. But I think we've spent some time starting to conceptualize where cycling might fit into the bigger kind of picture. And right now, Michelle, chime in if you would like to, but I think that we've started to conceptualize this as part of an in-bed rehabilitation strategy. So I think it could be one way of achieving some of our in-bed mobility and range of motion goals. Michelle, do you have any further thoughts?
It's we're actually, so stay tuned. We will be inviting people who are interested to join a CIHR grant that'll put in March, where we can try to study. I'm really curious to understand from physiotherapist perspectives, from physician perspectives, and also from hospital administrative perspectives about incorporating cycling for the right patient at the right time during their ICU stay as part of usual care. I'm not aware of many systematic reviews that have shown a reduction in ICU length of stay and hospital length of stay with an improvement in patient physical function for any ICU intervention, mechanical ventilation, drugs, or whatnot. So this is something that if we can reduce ICU length of stay, then does it mean that for 50 patients, for the sake of argument, you've got 50 patients, does that mean that we can ensure that someone who's about to have elective surgery and requires an ICU bed for monitoring, we can ensure that they can move forward with that? So it sort of speaks to some of the healthcare pieces around the pressures on the healthcare system, but it also might require a change in how we approach rehab for patients. Amy, what do you think?
Along those same lines, I was going to say, well, let me start by saying thank you for a wonderful presentation. Heather, I hadn't heard you actually give the presentation, so it was so nice to see you do that on that great body of work, and to see everybody involved. Thank you so much. And Michelle, it's always great to go back and look at the data again to see if it pops up anything else in our heads about, did we miss something? What else do we need to follow up on? So thank you again. Thanks, Allison, for the question. I think it's pretty clear from the systematic review that there's a signal with cycling. I don't think at this point in time, I think we're approaching it, but we can't tell exactly who would benefit the most. And so with that said, it would be great if we can combine data again, across the studies that have used cycling to say, is it the frail people? Is it those who are frail? Or, who is it really? And do a test for who we really think could benefit. Or the opposite. Is there a signal that we have that we know it doesn't matter? I think it could be approached in both those ways. In addition, this is going to be an and I think we need to have an overhaul of how we do ICU rehab. Even though I can just give an example here at Duke. I think we've made great strides in our ICU rehab, and it continually gets better over time. So you might ask, well, where is this need for overhaul? I don't think we have enough personnel to actually do what patients need. So I think in a way we still continue to compare oranges and oranges in a way. Because I really think to give CYCLE its due, I think we need to have additional personnel available to be able to help with the setup and really get patients that, regardless of whether they're ambulatory or not, because I think we can actually, with CYCLE, there's so much capability of us being able to actually tailor the intervention to meet meet patients where they are physiologically that we haven't really tapped into yet. So I love it that there's a signal already, because we haven't done that yet. Imagine when we actually tailor it, what we might get. That's a whole other study. I may not be doing this when that occurs, but anyway, I think there's just untapped potential. And the same way with the usual care. We do pick out of an assortment of strategies that we have, but where's the protocol to actually direct the tailoring of those strategies? We haven't done that yet. So that's what I sort of mean by overhaul. So I think we have great potential. We've improved. We've learned a lot. I still think there's a lot we can do, but we've started the process. And there are some of my suggestions of where we need to go next.
Thanks, Amy. And I appreciate what you said, and also what Heather said, starting to see where cycling might fit. I do believe people are looking to cycle personnel for what do we do with this information, and not just the single trial, but the body of evidence. And I know we keep kicking the can down the road, but I think it's important to get specific if we possibly can. And I appreciated what Heather was saying about for those people who are in bed, this is another tool. Obviously, if someone can stand and walk, better have them to do that. And I realize we're not in the business of making guidelines per se. And maybe that's all we can do. This is a tool for people who must be in bed or largely in bed, and it could be a good way to use the bikes that are kicking around, as Alison pointed out. And it maybe shows promise for in-bed exercise of a more rigorous kind, like the arm cycling that Michelle and the whole team's been thinking about. Amy has a thought.
Yeah, thank you, Deborah. I wonder if it's not an or, but an and. Meaning, and I appreciate what Heather said, maybe, people who are mobilizing, we don't need to do, but I'm not sure. Because the outcomes are still not where we need them to be. So even if we are getting rehab on the floor, and we have the data now to say, well, there's that 90-year-old, even though they had the opportunity because they were there in the hospital for 3 weeks, they were in the ICU for 11 days. So what happened the rest of the time that they're coming out with still poor outcomes? So is there an and? Do we do a cycle with usual care in the ICU? And what do we need to continue to go to the floor to actually move the needle? Because we may be moving the needle, but perhaps without the continuation of something really, that would pick up the intensity afterwards, when they're more capable, without that actually being tailored, do we lose some of the gains that we may have to, that we may be actually initiating physiologically that we may not be seeing, you know, on the outside with sort of the physical function measurements we have?
Right, right. And I'm keen to hear what Ian says, but if you don't mind, Ian, I'll just reflect on that. I mean, it's hard to extrapolate the cycle results to the ward, even though, like, I agree. And maybe it should be an add-on for everybody. That's another concept. You know, even if you are walking, still be great to do extra in-bed cycling. That may well be the case, but I just feel like some sort of direction is, or a nod to something would be useful. Like I'm sure Michelle will agree, our own physiotherapists at St. Joe's are sort of like wondering, like, what do we do with this information now? And I think that's a future conversation. I know Michelle and the whole cycle team with Jeff and Heather and others are planning, but I do think, and I can't remember when this call ends, was probably right now, but anyways, I'll shut up so Ian can talk. But I feel like we shouldn't go silent on this at the moment. Ian, sorry, what do you think?
No, gosh, no. I was kind of thinking along the same lines, and Michelle, I obviously am a huge believer in this and have been all along. And it's tough though, right? This is, you know, this is like telling people, go eat your vegetables and have an active lifestyle. Everyone knows it's good and you should do it, but prove that it's good. It's hard to do. And so it's exciting that this is out there. And this may seem like a bit of a crazy thought, and it would be actually very difficult to do, but you know, my sense, at least in my world, is a lot of intensivists are aware of this body of literature, but it's been going on for a while. There's a lot of different papers. There have been some negative trials. Would you consider an editorial to a high impact journal that it's the reason it'll be hard is because you've got to summarize a lot in a very, you know, it's got to be 750 words or less, which is difficult to do, because I think people might read that, right? Like in a snappy title that, you know, here's the summary of cycling data in the last 15 years, and here's what to do with this body of evidence right now, and here's what we still don't know, something like that.
Thanks for that suggestion, Ian, and thank you for supporting us from the get-go. It in just so many ways. So our systematic review will be used by the European Respiratory Society and the American Thoracic Society for a guideline recommendation. It's tricky. So cycling isn't for, so I think some of my take-home messages is that cycling isn't for everyone. Cycling is part of the toolkit for someone who's doing in-bed activities. We may need to think out of the box about how we deliver treatments in the ICU, because as part of CYCLE, we trained people who were not physiotherapists, but did have ICU experience to do in-bed cycling and monitor the patient. I think monitoring the patient is critical. So do we think of a potential model where the physiotherapist determines who might be suitable for cycling during their ICU stay? They might be the ones who might say, okay, well, this is a person who's suitable for cycling and I need to supervise them, or I might be able to delegate it to someone else. Can we work with other people who are already employed in the ICU to assist with setup, takedown, and cleanup? We might need to deconstruct this, which will require coordination, but it might be blowing up what we're currently doing, because maybe the physiotherapist's time is better spent working on active mobility activities out of bed if someone is suitable and working with the really sick patients. But that's a bit of a different setup, but I think we can explore it. And I think trying to bring in hospital administrators to help them understand the evidence managers and the physiotherapists themselves, so that there also aren't unintended consequences for for rehabilitation outside of the ICU, given the current staffing constraints.
Thanks, Michelle. Good luck. It's a tall order, but I'm sure you'll knock it out of the park once again.
Well, we'd love to have you involved. And as Deborah mentioned, we're also looking at doing some pilot work around arm cycling. So we'll be reaching out to people to gauge their interest in participating in one or both studies. And I think if we involve people, that could be really new and involve patients. I think that would be wonderful. However, we do have the system, we have an economic evaluation that's coming out. And then we will do an economic model, because the economic evaluation is largely driven by the cost of hospitalization. So once we do a model-based economic evaluation, it's going to show, I would be surprised if it does not show, the cost savings to healthcare systems. So be on the lookout for our economic evaluation. And thank you everyone so much for being leaders at your sites, for helping to galvanize the people around you, and to help us see this through, especially through a pandemic and all of those things. So there will be more to come, and we'll study usual care as well. I'm happy to stay on and talk longer if people have time. However, I do appreciate that we have run a few minutes over.
Thank you so much.
Thank
Lovely.
Thank you.
To see you all.
Thanks all.
you. Bye.
Bye.
Bye. Bye.